So I'll be speaking mainly about the perioperative management of stroke, Parkinson's disease, and seizures. As Fred said, Deepak will be talking about the perioperative management of spinal cord and peripheral nervous system diseases. The World Health Organization has defined strokes as a focal or global neurological deficit of cerebral vascular cause that persists beyond 24 hours or is interrupted by death within 24 hours. A TIA is an acute loss of brain or ocular function with symptoms lasting less than 24 hours. Now, a stroke in the perioperative period can occur either during surgery or up to 30 days from the time of surgery. The majority of strokes usually occur within few days after the surgery and not during the surgery. The incidence of strokes depends on the complexity of the procedure and the type of the procedure. As you can see, like general and orthopedic surgery, the incidence of stroke is low. It's less than 1% versus other surgeries that involve the heart or the blood vessels, which go up to 7 to 9%. On the other hand, the mortality after a perioperative stroke is high, is around 25% in any procedure. So that's why it's significant to try to prevent such strokes. Now, the postoperative, the post-mortem studies and the radiological studies have shown that the majority of strokes are ischemic in nature. The majority of the perioperative strokes are ischemic, and only 1% is hemorrhagic. For some reason, the studies have shown that in a non-cardiac and non-neurosurgical procedures, it's a higher incidence of thrombotic strokes versus embolic strokes. Like in cardiac and vascular surgery, it's more embolic strokes that are the cause of the ischemia. And 14% of strokes during non-cardiac, non-neurosurgical are associated with atrial fibrillation. Now, the main causes for perioperative strokes are cerebral atherothrombosis, atrial fibrillation, dehydration, hypotension, perioperative systemic hypercoagulable state, paradoxical embolism, patent foramen ovale, arterial dissection, fat or air emboli. And so who's at risk for strokes in the perioperative period? It's usually elderly people more than 70 years. Female sex is more than male for some reason. Then you have the chronic diseases of hypertension, diabetes, renal insufficiency, and cardiac diseases, valvular diseases, arrhythmias. History of strokes, TIA, carotid stenosis, puts you at a high risk, of course, for strokes. Discontinuation of antithrombotic therapy before surgery puts you at high risk. And then whether the procedure is elective or urgent. Urgent is higher risk, and so is general anesthesia versus regional anesthesia. And again, the type of the procedure, the complexity of it, is it cardiac, is it vascular, or is it orthopedic, as mentioned in the previous slide. So I usually get a patient referred from pre-screening or from the surgeon because the patient has a history of a TIA or a stroke. They want me to clear him for surgery. So one needs to make sure that this patient has been properly investigated for a stroke. And we usually do the MRI, MRA of the neck and head or carotid ultrasound, EKG, echocardiogram. If a young guy had a stroke, I'd like to do a TE echo to rule out PFO. And then a blood screen, including hypercoagulable state. Now, sometimes a patient has a stroke while waiting for surgery, or the surgeon asks me, when can we do a surgery after a stroke or a TIA? Usually, we do not like to have surgery done for at least 2 months after a stroke. And the reason is because after a stroke, there is disruption or impairment of the autoregulation of the brain. So the perfusion of the brain becomes very dependent on the blood pressure. So any drop in blood pressure might cause decreased blood flow to the brain. So we usually don't like to have any procedure before 2 months after a stroke. If it is an emergency, then we have to pay very close attention to the perfusion to maintain a good blood pressure and hydration. So after investigating the patient, what will we do? Let's say we found that the patient has a 70% or more stenosis of his carotid arteries. The recommendations are that we should do a revascularization, endarterectomy or stenting for anything more than 70%, even if it is an asymptomatic stenosis. For people who have less than 50% stenosis, even if they're symptomatic, surgery is not recommended. Now, between 50 and 70, that's a gray area. And if it's symptomatic, some people tend to revascularize. Others can treat aggressively with statins and aspirin. So that's not a very definitive, there's no definitive recommendations there. Now, people who have, patients who are on anticoagulant, what shall we do with that before the surgery? So if the procedure is a low risk for bleeding, then we continue the anticoagulant. If it's a high risk, which majority are here, then, and the patient has a high risk for stroke, like mitral valve prosthesis, aortic valve prosthesis, atrial fibrillation, CHADS 3, 4, 5, 6, or TIAs or stroke in the past 3 months, we would usually discontinue the anticoagulant for a few days and bridge them with low molecular weight heparin. With patients who are on antiplatelet agents, and again, if low risk for bleeding, we continue the antiplatelets. If high risk for bleeding, then we discontinue the antiplatelets for 5 to 7 days before surgery and then resume it 24 hours after surgery. Now, during the operation, the important thing is to maintain a good blood pressure, especially if people have some stenosis in the carotid artery. And the ideal blood pressure depends on what's the baseline of the patient's blood pressure. So each patient has his own blood pressure that should be monitored before the surgery. And during the anesthesia, it should be 20% of baseline. Shouldn't be lower too much and shouldn't be very high. Now, if a patient had a stroke immediately during the surgery or immediately after surgery, you know, a skilled nursing staff should be able to detect that, because it's not easy to detect a stroke immediately after surgery because of the medications, drowsiness, the patient's not responding well. So once it is suspected, then a CAT scan of the head is done to rule out any bleeding. So suppose we detected a stroke. Thrombolysis is contraindicated after a surgery. Now, some people are using intraarterial thrombolysis with TPA, but in general, the intravenous TPA is contraindicated. So the only thing is left is if somebody had a stroke after a procedure, then you just have to maintain the blood pressure, control fever, and then use antiplatelet agents. Now we go to the Parkinson's disease and the perioperative management of Parkinson's disease. So Parkinson's disease is a clinical syndrome characterized by masked facies, tremor at rest, bradykinesia, rigidity, shuffling gait. The treatment of Parkinson's disease includes levodopa, which is the main medication, then dopamine agonists, amantadine, anticholinergics, MAO inhibitors, COMT inhibitors, deep brain stimulation of the subthalamus and the globus pallidus. So the challenges that we face with people who have Parkinson's disease is that we're going to disrupt their medication schedule. So there'll be more rigid, more bradykinesia, and inability to take medication by mouth after the surgery. Now, this is not a major thing when you're having orthopedic surgery, because usually if you do the procedure in the morning, then in the evening we can resume the oral medications in most cases. But patients who are undergoing abdominal surgery, sometimes you need to be MPO for a while, and that becomes a problem. And the other things, besides reduced mobility due to being bedridden and not taking the medications, there's the medication interaction and side effects, which I will explain a little here. So what do we recommend for people who are undergoing surgery and have Parkinson's disease? In order to keep the patients on the schedule with their medications, we would prefer that the surgery be done in the morning so that they can resume their medications in the afternoon after the surgery. Now, a lot of patients with Parkinson's disease have difficulty swallowing, and therefore we have to be careful with aspiration pneumonia. So there should be intense focus on spirometry, sometimes intubation, aspiration precautions, frequent suctioning, etc. The MAO inhibitors, which are used for Parkinson's disease, namely risagiline and selegiline, which is L-Dipril and Azilect, should be discontinued 1 to 2 weeks prior to the surgery because they can interact with the opioids, which are going to be given after the surgery, and cause a fluctuation of the blood pressure and sometimes a serotonin syndrome, which can be quite lethal. And a lot of patients after surgery will have nausea. So we have to avoid the dopamine antagonists, which are like metoclopramide, promethazine, which is Reglan, and Compazine, because these are anti-dopamine agents and worsen the Parkinsonian symptoms. So we use ondansetron, which is Zofran, or domperidone, which is Motidium. Now, sometimes people who have a fracture of an arm and they have a tremor or severe dystonia and continuous shaking, so after the surgery you need to immobilize this arm, otherwise it won't heal. Then we use chemical and physical restraints to sedate the patient. Now, I mentioned about surgeries that are abdominals. And for example, the patient cannot take MPO for several days, or is MPO for several days. Then we don't have too many intravenous medications that we use for Parkinson's disease. Most of them are oral medications. The only one we can use by injection is apomorphine, which is a dopamine agonist. So we use it subcutaneously for these patients. But as I said, in this hospital, it's mainly orthopedic hospital, so we don't have that problem. And then people who have Parkinson's disease have a lot of fluctuation of blood pressure because of their autonomic dysfunction. And plus the levodopa, carbidopa that they're taking can cause also a drop in blood pressure. So we have to have adequate monitoring of the blood pressure and adequate hydration. People with Parkinson's disease are at higher risk of psychotic symptoms or cognitive impairment after an operation. So here again we have to avoid the antipsychotics that can aggravate Parkinson's disease, which are the dopamine antagonists like Haldor, haloperidol, risperidone, Zyprexa, and we use quetiapine, which is Seroquel, or clozapine. And it's very important to start physical therapy early after the operation, so that you increase mobility, you avoid deep vein thrombosis, you avoid aspiration pneumonias, bed sores, etc. Now, the last thing I'm talking about is the seizures. So I usually get a referral because the patient has had a history of seizures and is going to have a procedure done. So first thing I do is check whether he's compliant with taking his medications by doing a blood level on his medication to see if it's therapeutic or subtherapeutic. If it's subtherapeutic, then I boost him up before the operation so that it will be adequate and therapeutic. Then I talk to him about things that might provoke seizures. These are sleep deprivation, and then drug and alcohol use. Like, alcohol can trigger seizures, and also withdrawal from alcohol or withdrawal from drugs within 48 hours from the procedure can, bring on a seizure. So we try to to convince him to stop the alcohol at least 2 weeks before the operation or any drug use. There are some stimulants that can trigger seizures. We check for any metabolic abnormality that can lower the threshold for seizures. This is a blood screen for electrolytes and so on. Now, the Mayo Clinic has done a study between 2002 and 2007 of like 650 patients who had a seizure disorder and were going to have surgery. And they found that, this is a retrospective study, they found that 22 of these 600 patients had a seizure after surgery. The two risk factors for these seizures were when was the last seizure, when did the last seizure occur, and what was the frequency of seizures before the operation. So people who have had frequent seizures before the operation or had a recent seizure are at higher risk of having a seizure in the perioperative period. So it had nothing to do with the type of the procedure, the anesthesia used, the medications used. It only had to do with when was the last seizure or what was the frequency of seizures before the operation. Unfortunately, with seizures, we have a lot of intravenous medications we can use, unlike Parkinson's disease. So if somebody cannot take anything by mouth, we can use Dilantin, lorazepam, valproic acid, or Keppra intravenously. So that's my talk.
So thank you, Amin. That was a great talk, and you made my talk much easier because mine is a much simpler, somewhat less interesting, but I'm going to make it more interesting. And you know that New England Baptist is a very large, major orthopedic and spine hospital in the country. And just last year alone, there were about more than 6,000 discharges from the orthopedic clientele, which is far more than what Brigham and Mass General did. So all these people in the audience, the specialists, and particularly the intensivists, who are the first-line responders, have seen a variety of neurological complications, including the ones which Amin has described, and also a lot of peripheral nerve and neuromuscular complications. So we are kind of a little bit familiar with those, and later on we'll invite the audience to help us out and answer questions. So, you know, there has been an exponential rise of these orthopedic procedures, and once about 95% of these procedures are having no complications at all, and only about 5% have complications. That includes the peripheral nerve, the neuromuscular junction, the spinal cord, and the nerve roots. So really everything is good, and good news is really no news. But once a complication occurs, it's big news. And the complication necessarily may not be malpractice, it may be just a maloccurrence. And then suddenly a SWAT team of people, the intensivists, the ICU trained nurses, the doctors and the specialists, they all come in and try to help out and sort out. But keep in mind that in the initial phases of post-operative period, I don't want to use the word, the examination is very corrupted because there's so much confluence of diagnoses that one cannot make, as he suggested, a diagnosis of stroke. And similarly, one cannot make a diagnosis of myasthenia, neuropathy, or any critical illness process which might affect the peripheral nerves and muscles. So sometimes it takes a little bit of time to make the diagnosis, and that's quite normal. But once we make a diagnosis, we are all kind of equipped with what to do, and that's what it is. So the idea today is not to go in depth of these complications which involve anywhere from spinal cord to the peripheral nerves and muscles, but to highlight and make you aware what can happen. And of course we can take questions, and there is some bibliography at the end which you can read and get help from. So first of all, as we see that there are some direct complications of surgery, and we know direct complications mean if one does a hip and there is a proximity of the femoral nerve and the sciatic nerve, or one does a shoulder, there is a brachial plexus, and similarly the knee and the foot. So all these things can be involved and produce peripheral nerve involvement, but there are a lot of indirect complications. Now these are some of the common surgeries which are performed at the New England Baptist Hospital, and obviously all of them are done by experts, and there is an excellent nursing care, operative and post-operative care. But then we encounter patients whom we least expect to have complications, and the surgeon and all the treating physicians who are there, they themselves are surprised, how did that happen? Everything went well in surgery, but there's so much of trauma during surgery and blood loss that complications arise unexpectedly. Now, the common nerves which we see which are involved in the surgical procedures which may produce nerve damage are the brachial plexus, and particularly if you have shoulder surgery. The femoral and sciatic nerve is involved in hip replacements, peroneal nerve in knee replacements, and tarsal tunnel syndrome, just like the carpal tunnel syndrome, is a funny syndrome where at the bottom or the top of the feet you have numbness and tingling, and when there is manipulation of the knee or the foot, or there is local nerve block or fasciotomies, those nerves can be irritated and produce these symptoms. And one of the most bread and butter surgeries in spine is the anterior cervical discectomy and fusion, and the close proximity of the cervical sympathetic trunk is very vulnerable to produce Horner syndrome. So this is how the brachial plexus, which in our anatomy days we are familiar with, and the proximity to the shoulder. Now remember, the shoulder is way out of the brachial plexus, so what could happen? The only reason one could involve the brachial plexus is a traction using retractors. So, and these injuries to the brachial plexus are very often temporary and they recover. And here is the hip with the femoral nerve, and less than 5% of cases of hip surgeries involve the femoral nerve and produce weakness of the iliopsoas or the quadriceps muscles. And often it's not a direct trauma, but it's a retraction or the pulling and the mechanisms to clear the hip of any muscles, and the nerves and the inguinal ligament produces this. Here is the hip with the sciatic nerve next to it, and this is also less than 5%, where you see that soon after a hip replacement which has been very successful, the original hip pain has disappeared, and yet you find that the patient may be left with a little foot problem, either a foot drop or difficulty with extension of the ankle muscles. During knee surgeries, the peroneal nerve wraps around the outer border of the fibula, and one can occasionally see the peroneal nerve is involved. Rarely is there a severance of the nerve, but often it's a neuropraxia, so the recovery is also very favorable. Now, in the ankle and foot surgeries, you see an enormous mesh of nerves in the bottom of the feet. These are the plantar nerves. So we all have plantar fascia, and endoscopic plantar fasciotomy is a very commonly done procedure. And when that's done, one can easily conjecture that these nerves are irritated and produce the tarsal tunnel syndrome. Here is an example of spine surgery, and in spine surgery, all the neurovascular bundle and the muscles are retracted when the anterior cervical discectomy and fusion is done. And with that in mind, this cervical sympathetic trunk can be involved, and when it is involved, it produces ptosis or Horner syndrome. Often the recovery from Horner syndrome is over 90% or 100% within a few weeks to a few months. So these are direct impact of the surgery to the various nerves. Now, the indirect assumptions which we can make about certain nerve symptoms which follow surgery are when the position of the patient has been in jeopardy, and one can produce ulnar nerves. One may have ulnar nerve symptoms or funny numbness in the thigh or a foot drop, and similarly in rehabilitation crutches can produce carpal tunnel syndrome and brachial plexopathy. Here's the ulnar nerve, and the patient is lying on the operating room table or even in the recovery area, may have compression of the ulnar nerve, particularly if the patient is lean and thin and there is less of fat padding around the nerve, the ulnar nerve may be involved. Similarly, when the crutches are used or the walkers are used, they can have symptoms which relate to the median nerve. Now there are indirect complications which have become really difficult to diagnose, and sometimes it does take a long time, perhaps up to a few days, before we can make a diagnosis. And one can encounter loss of blood pressure, sepsis, and prolonged intensive care and mechanical ventilation. And once we have these conditions, one is faced with the daunting task of making a diagnosis of critical illness myopathy or neuropathy and a spinal shock. I'm going to dwell into these in the subsequent few minutes, and then lo and behold, there is another group of conditions whereas the surgery is done in the hip, but within a few days these patients start having severe shoulder pain and atrophy and numbness, and they develop a condition called neuralgic amyotrophy. And sometimes even with the hip or knee surgeries, of course these are extraordinarily rare events, one can have a transverse myelitis and the spinal cord may be involved with an immune mediated mechanism. Now there are some indirect complications which need to be addressed too, is the neuromuscular junction. And myasthenia in particular, when we find in post-operative patients, they suddenly become extremely weak, have dysphagia, you are unable to take them off ventilators, they have ptosis, and that's a myasthenic problem, and sometimes they go into myasthenic crisis. And another important thing, item to remember, is chronic regional pain syndrome. Now, chronic regional pain syndrome is like if a patient has a knee surgery and within a few days starts having burning, tingling in the top of the foot with normal motor function and allodynia or hyperalgesia, and within a few days to a few weeks they start having changes in hair growth or texture of the skin. That's called complex regional pain syndrome, and that's like autonomic or mostly sympathetic overactivity, so that's called complex regional pain syndrome. Now what is this critical illness myopathy and neuropathy? This is one of the most commonly associated perioperative neurological peripheral nerve complications we see. Now one might be surprised in this room that the incidence of this rapidly evolving muscle and nerve symptomatology in the form of weakness, loss of reflex, and occurs in up to 50% of cases, and the typical course is 33 to 50%. So a vast majority of patients which we see with prolonged ventilatory failure, little elevated diaphragm and weakness of the legs and the arms, we kind of underdiagnose and we let it go because the normal course of these people is that they improve. And the hallmark is there has to be a critical organ failure, whether the failure is of the heart or the liver or the kidney, severe hypotension or sepsis. They all can give rise to this form of critical illness myopathy or neuropathy. Now when we as neurologists are called, we are asked what's happening. Now obviously we can't say whether this is Guillain-Barré syndrome or whether it is myasthenia or critical illness neuropathy and myopathy, because the occurrence of all these 3 or 4 diagnoses has a similar background. There has to be a critical organ failure. Then we look at all the charts and find out, is there an iatrogenic basis for it, any of the medications on board, or has the patient been given a lot of steroids, and is the patient having insulin resistance or is very hyperglycemic, because all these predispose to the development of critical illness myopathy. I'm sure Amin has seen, and we have done electrophysiology in many of these patients, and electrophysiology is really confirmatory. We have done phrenic nerve conduction studies in the ICU and EMGs, but the key issue here is that we are challenged, and you say, well, doc, why are you saying it's myopathy when the CPK is normal? So the muscle has to necrose to leak the enzyme to produce a high CPK, and if you don't have that, then the diagnosis remains a little bit in the air, but the EMG really confirms it with small units and polyphasic units. But the natural course of this is improvement in few weeks to few months. Now, often it can occur and the patient is in the ICU for months and months, or in weeks and weeks, and similarly in the rehab, and there is no predictability how long will it take to improve 50% or even more. And one is asked, will the patient ever be able to walk with unassisted or with crutches, and you cannot predict that. But the fact of the matter is that if we can avoid critical organ failure, if we can avoid high dose steroids, if we can avoid excessive hyperglycemia, this is more or less lesser of an incidence or preventable, and perhaps the outcome is much better. So those three things have to be kept in mind for this particular condition. Now we have these immune mediated complications. Patient is having an unrelated hip or shoulder surgery and comes up with a transverse myelitis. Now, what is going on? I mean, obviously the two things are completely unrelated, but that's an antibody immune mediated and very poorly understood condition, and just because we don't understand it, we call it immune mediated, and of course the anatomic diagnosis makes it like a transverse myelitis. Neuralgic amyotrophy, as I've already mentioned, is a painful shoulder girdle weakness, and that is immune mediated. The pain is so excruciating and severe, patients wake up after knee or hip surgery, very rare again, but a well recognized entity, and they just can't move their shoulder. The arm is so excruciatingly painful. The MRIs of the cervical spine are normal, and you don't know what to do, but suddenly within 1 week the scapular muscles are completely wasted and atrophic. So that's neuralgic amyotrophy. The natural course of neuralgic amyotrophy is that 80% improve and the pain disappears within 2 to 4 weeks. And pain really disappears, but the muscle atrophy sets in. Now imagine this is a peripheral nerve complication of an unrelated surgery, but it is slowly being recognized as it can occur. And then the Guillain-Barré syndrome, where is again a painless weakness of the lower extremities, and followed by ascending paralysis and ventilatory failure, and those things which accompany autonomic issues and loss of motor and sensory function. Now we have the neuromuscular junction. Now we have these ICU patients and they can't move. You can't wean them off. Nothing is known what's happening. Immediately we can't do an EMG to find out if there's myasthenia, neuropathy or myopathy, because it's such a difficult environment to perform those tests, although we have performed a few of those, that we have to bank on clinical acumen. Now we find ptosis, diplopia, and then we look at the chart. There has been a certain anesthetic or there have been some antibiotics or antiarrhythmic agents and calcium channel blockers, and these are notorious, some of them, to produce a myasthenic crisis. And one of our own papers, which Volny Sheen and myself wrote, was these patients, because of pain, their gabapentin was increased and they developed myasthenic crisis. So one has to be careful in looking at the chart very carefully if one of the complications which is in the form of generalized weakness, dysphagia or diplopia, has an iatrogenic cause or not. And we can find that one of these could be culprits. Now when you do an antibody to the acetylcholine receptor in these patients, it will be negative because there is no antibody, except that these are chemically blocking the cholinergic uptake or the acetylcholine uptake in the muscle end plate. But if you have an existing myasthenia gravis, it can be severely exacerbated or aggravated by use of a higher dose of gabapentin. And surprisingly, when gabapentin is given, the acetylcholine receptor antibody also rises. So in our case, it rose from 5 to 35, and then we reduced the gabapentin, it came back to quite being closer to. Now, steroids is a very tricky thing, and we tend to use steroids in a higher dose. And it is notorious to produce critical illness, myopathy, neuropathy, as well as myasthenia. As much as it is used for treatment for myasthenia, it's also counterproductive that it may cause myasthenia. And in a large number of studies, people have addressed the issue of steroids as well as sugar levels. So the insulin resistance factor does play a role, and preferably in a post-operative period, it's good to have a reasonable sugar, because high sugars is a stress response to surgery and anesthesia. But if you keep the sugar very high, it makes these patients vulnerable to peripheral neurological complications. So you want to keep the sugar level a little bit low. Now these are, if some are interested in some of the references, they are here, and obviously this was not an attempt to detail everything in its entirety, but to make the audience aware what can exist in peripheral nervous and spinal cord in a post-operative period, although it's quite rare and perhaps less than 5% in most of the patients. And we also want to say that we as a group have, because of the high complexity of cases and the higher volume, we have seen virtually all these cases, so it's like a educational experience for all of us, and thank you.